So thanks everyone for being here. We are excited for our Department of Nursing Grand Round speaker this week. Dr. Catherine Marks is a PhD and is an assistant professor of otolaryngology here with us. She directs the Marks Research Lab and is a practicing speech-language pathologist at the Emory Voice Center. Specializing in the treatment of voice and upper airway disorders, her primary research interests include implementation science, laryngeal dystonia, and related neurological conditions, and quantitative measures of voice disorders. And we are excited to learn more about hoarseness from her today, something that I think many of us see both on the inpatient and outpatient sides. And I'm eager to benefit from her expertise as we learn more about it. So thank you, Dr. Marks.
Thank you for having me. Can everybody hear me okay? Okay, great. All right, so a little bit about me. I saw as part of the description that they asked that you all ask speakers to tell a little bit about ourselves. So I got my start in the voice world as a high school musical theater nerd, and participated in a lot of musical theater productions, but also some summer programs. And in joining some of the summer programs, I heard a lot of people talking about overuse of voice and, you know, whether somebody could develop nodules over time. And so I became hyper aware of vocal health and was really interested in learning more about it. I then went on to be a music major in college and found myself talking more about the physiology of singing rather than actually singing. And my voice teacher encouraged me to go observe at the Emory Voice Center. So I did and fell in love with what the speech pathologists did there, which I'll tell you more about. And then from there on, launched my clinical career. So I went on to pursue a Master's of Science in Speech Language Pathology at the MGH Institute of Health Professions in Boston. I did a clinical fellowship and practiced for another year in Michigan. And then I returned back to Boston and worked as a research SLP while getting a PhD. And just recently completed my postdoctoral fellowship back in the fall. So I joined the Emory Voice Center as an assistant professor this year in September. And so as I'm starting my own lab, my overarching goal is to establish a research laboratory to translate novel assessment and treatment tools to clinical voice practice. My mission is to improve assessment and patient care for voice disorders in diverse populations. And my vision is to translate novel assessment tools to clinical practice and advance voice assessment beyond the walls of the clinic. I'm not going to bore you with the details of my research today. I am going to keep it broad and talk more about hoarseness. So what is hoarseness?
I'm so sorry to interrupt.
Sure.
I think you're sharing and have hovered, I think, over the top bar.
Oh, she's going to get something. Oh, yeah. Here's the packet.
Perfect. Thank you.
Okay, sorry about that. All right, so covering today, what is hoarseness? What do we ask in a history? What are some red flags? When should you refer? What happens at the Emory Voice Center? And then I'll show you some examples of things that you might not get to see that we see clinically on our voice evals. And then I'll end with a few cases. So what is hoarseness? In Michigan, I commonly had patients come in and say, oh yeah, my voice is a little hoarsey. I haven't heard that so much here in Georgia, but that is something that in Michigan seemed to be a thing. So hoarseness is a non-specific term implying change in typical voice quality. I like to think of it as a mix of roughness and breathiness in the voice, and it consists of 1% of all primary care consults, so maybe not something that you see all the time, but every once in a while. So since hoarseness is sort of a non-specific term, what could patients mean when they say hoarseness? They could mean a complete loss of voice, so they're coming in without any voice at all, or aphonia. They might describe their voice as raspy, breathy, gravelly. They might complain of vocal fatigue or increased vocal effort. Their pitch may be unstable throughout the day, or they may have voice breaks. They may have some pain associated with voice use. Their voice might vary throughout the day or day to day, or they might have a loss of singing range or prolonged warm-up time if they are a vocal athlete. So it's important to ask your patients to be specific when they talk about their voice. So ask them to describe it. So these are the things that we in the voice clinic talk about in terms of taking a history. How long have the voice changes been going on? Ask them to be specific. Was there any inciting event? So they may say things like, oh, I lost my voice after cheering at a football game, or cheering at a concert, singing loudly at a concert. And that might indicate some sort of trauma has happened to the voice, like a polyp or a hemorrhage. Or they may say, yeah, I lost my voice with an upper respiratory infection, and my voice just hasn't come back, even though my cold is gone. Was there a sudden or gradual change? That can also give you some information. Something like a polyp or hemorrhage can happen suddenly, whereas nodules or muscle tension might be more of a gradual change. Has their voice improved? Has it worsened? Does it ever return to normal? If it does return to normal at times, this might be an indication that muscle tension could be the primary cause. Of course, we can't assume that, but that does give us some more information. Does anything seem to make it better or worse? Have you had any recent surgeries or hospitalizations? So have they been intubated? Have they had any kind of surgery like thyroid surgery or cardiothoracic surgery, where we might be worried about an injured recurrent laryngeal nerve? Any pain associated? Do they have cough? Do they have dyspnea? Do they have swallowing problems? Do they use any inhalers? And have they had a history of thrush, for example? Any neurological symptoms?
We literally had it last week.
Then, of course, you want to think about the risks that they have for head and neck cancer, smoking, alcohol use, whether they've had Gardasil, whether they're at risk for HPV type changes, as that's now
Anything that John told me last week, just to continue.
I'm so sorry, Dr. Marks. We'll keep working on mute.
Okay. No worries. All right, so what are the red flags? When hoarseness presents along with pain, particularly if it's one-sided or if it's ear pain, or you notice a mass somewhere in the head or neck, the person has had unexplained weight loss, night sweats, unexplained fevers, and also considering their risk factors for head and neck cancer, you want to go ahead and refer urgently. And maybe that doesn't mean that they're going straight to the ED, but you do want to follow up with the person that you're referring to in order to expedite the evaluation, because we don't want them to have to wait 3-4 months to get in to be seen if we think it could be cancer. Regardless, persistent hoarseness is never normal. So hoarseness that lasts longer than 2 weeks needs imaging, and it needs a special kind of imaging. So don't just assume that it's reflux or allergies if you haven't actually had them looked at with our scope. So for non-specific general symptoms, a general ENT or APP might be able to appropriately assess, but for hoarseness lasting longer than 2 weeks, patients need video stroboscopy, which is typically only available at a voice center or a laryngology practice. So general ENTs typically don't have that equipment in office. Why does it matter? So I'm going to show you 2 videos. The left is a flexible plain light exam, so without video stroboscopy. This is starting in the nasopharynx and peeking down to look at the vocal folds below. So they're looking at velopharyngeal function. and then proceeding down further into the larynx.
Okay, can you stick your tongue out before for me?
Checking the base of tongue.
And count from 1 to 10.
1, 2.
And we can see gross movement, so abduction and adduction of the vocal folds.
Can you say E?
But when we have them hold out a sustained sound, we can't see the cycle to cycle vibration. Instead, it looks sort of like bees' wings. The vocal folds vibrate faster than our eyes can see, so we don't get a clear image of vibration. We can see closure patterns, so in this case, the vocal folds are not closing all the way. There's a spindle-shaped gap here, but we can't see much about vibration. This video on the right is a rigid scope that goes in the mouth. You can get video stroboscopy with the flexible scope or the rigid scope. This one just happens to be the rigid scope. And we pair it with a strobe light, which gives the illusion of vibration, so that we can see cycle to cycle differences. We're actually able to see the opening and closing, looking at how the vocal folds vibrate. There's a mucosal wave we can see. And if there were a lesion, there's not in this case, but if there were a lesion, we would be able to see it and see how the vibration is impacted from that lesion. So again, video stroboscopy is really important for hoarseness because hoarseness itself implies an impairment of vibration. All right, so what are some potential causes? Most common cause is acute laryngitis, chronic laryngitis. The next most common is muscle tension dysphonia, and that's when there's nothing physically wrong with the vocal folds themselves. There's no underlying neurologic issue. It's just that the muscles have started to compensate for whatever reason, and it's producing bad voice, but there's no pathology on the vocal folds themselves. Benign pathology happens 10 to 31% of the time. Malignant tumors, 2%. Neurogenic conditions, such as vocal fold paralysis between 3 and 8%. And aging voice, 2%. And you may notice that allergies and reflux are not on this list. Of course, they may contribute to something like chronic laryngitis, but contrary to popular belief, not everything is caused by reflux and allergies. So your patient shows up with hoarseness. Now what do? Ideally, we have you refer to the Emory Voice Center or another laryngology practice, and the patient asks you, well, what can I expect at my appointment? So I'll walk you through what happens at the Emory Voice Center. So we are an interdisciplinary team. We come in pairs or teams of us. The interdisciplinary visit starts out with a speech-language pathologist, a resident, and a laryngologist. Typically, the SLP or the resident go in and obtain a history, and they will go ahead and do the scope to record a video of the vocal folds. And typically, you can let your patients know that this is often done with a spaghetti-like scope in the nose. It's flexible. It is not meant to be painful. We do provide numbing and decongestant to make it as least uncomfortable as possible. I won't go as far to say that it's comfortable. It's weird to have something in your nose, but it is not intended to be painful. The other option is we might look at the vocal folds with a rigid scope in the mouth, and that can be done with or without a numbing agent. Then after the scope is done, if the laryngologist wasn't already in the room, the team will round outside the room and return together to determine a plan with the patient. Then the laryngologist reviews the exam, does a physical exam, and makes medical or surgical recommendations. So if he's going to have them try any medications or she wants to take them to the OR, then those kinds of decisions will be made. And if applicable, then the speech pathologist will discuss behavioral management, including things like vocal wellness recommendations, as well as voice therapy. And if the patient is a candidate for voice therapy, then the SLP will go ahead and do a same-day acoustic and aerodynamic evaluation, recording the voice to look at the signals to gain information that will influence our therapy. So I want to pause here for any questions that you may have regarding history or when to refer. And I know that the larynx can be sort of a black box, so please don't feel like there are dumb questions if anybody has any. All right, so what might we see on exam? This is a typical larynx, so the vocal folds are nice and pearly white with no humps, bumps, or lumps. The edges are straight. These are still images, so we can assume that they get complete closure there. And thinking about these common causes of hoarseness, I'm going to show you some examples of videos. So this is a video of acute laryngitis. So they're not really getting any closure, a little bit at the anterior. And just to orient you, we're looking at a bird's eye view of the larynx. It's a mirror image, so the left vocal fold is actually on the right side of the screen, and the right vocal fold is on the left side of the screen. So vocal folds are not pearly white here, they're red and inflamed. A little bit is vibrating towards the anterior, but they have quite a big gap there. Vocal folds are very stiff, there's not much sound coming out. This is an example of a fungal laryngitis.
Okay, great. Comfortable?
So they're less stiff than the previous example, but still stiff, particularly when they raise their pitch. As we raise our pitch, the vocal folds stretch, so any kind of stiffness becomes more apparent, or lesions may become more apparent there as well. So in this case, we're looking at this white lacy stuff on top of the vocal fold edges, or the surface of the vocal folds rather. And in this case, this was somebody who was using an inhaler, who commonly had thrush in their mouth, and so in this case the thrush had developed on the vocal folds themselves, which they treat with diflucan. This is just a still image of a chronic bacterial laryngitis. So that was kind of it for the laryngitis presentations. Muscle tension dysphonia, or primary muscle tension dysphonia, is hoarseness that occurs in the absence of neurologic or pathologic conditions. So there are no lesions on the vocal folds, and instead the muscles are hyperfunctioning or squeezing together in an inefficient way. And sometimes this happens in response to an upper respiratory infection or other vocal injury, like yelling at a baseball game or having acute laryngitis, and the muscles sort of get stuck in this hyper-functioning pattern. The person's not realizing that they're doing anything different, but the muscles are preventing the vocal folds from vibrating and contacting in an inefficient way. And so this is one example.
And can you go a little higher? There you go. Good job. Breathe now. Good. It's feeling nice. No hollow. Swallow again for me. You're almost done. Turn your head this way. And a nice gentle high.
His anatomy was just a little bit difficult, so the scope was twisted. You can see that these muscles, the false folds, are engaged, covering up some of the vocal folds. We also see anterior to posterior constriction of the muscles. but you may have heard him say there's no evidence of a polyp. So in this case, it's muscle tension that's compensating. And now on to our benign lesions. This is an example of vocal fold nodules. Vocal fold nodules are always bilateral, and the baseline treatment for vocal fold nodules is voice therapy. Very rarely will they require surgery, and most of the time these can be managed behaviorally.
Can you go higher than that?
There's some mucus hanging out, but what we're looking at, the nodules, are these bumps along the surface or the vocal fold edges, mid-membranous lesions that are, again, bilateral, and you can see that they are touching first before the rest of the vocal folds touch.
Can you try and do it straight?
Which leads to some breathiness in the speech signal. These are a few different examples of polyps. They come in all shapes and sizes. They're same diagnosis, but they can present very differently. So it's important to consider a patient's vocal demands and anything that may be happening in their lives. If they're a performer, for example, we might want to know a period when they don't have performances coming up that they may be able to have surgery. If it's a everyday person that doesn't need their voice to sound perfect, they just were concerned that there's, they wanted to make sure that nothing scary was down there, then they may choose not to do anything at all. It's rare that the polyps will get bigger over time. And as long as it's not bothering them, there's no reason for going to the OR. But typically people are having, the people who get it tend to be high vocal demand users, like teachers, lawyers, preachers, singers. And in that case, they may opt to go to the OR sooner or start with voice therapy to see if that helps first as a less invasive option. So a little stiffness there along with the polyp that we can see on the left vocal fold, which again is on that right side. So that's a nice abducted view, little gelatinous polyp there. On the opposite end of the spectrum, we can have giant pathology. So this is actually like blowing in and out of the airway. Quite large. This is probably the largest one I've ever seen. And so something like this is likely not going to go away on its own, so that would definitely require a trip to the OR. And then another example, you'll notice this one is soft and gelatinous like the first one, but it appears red, which means there's a little bleed in it. We call this a hemorrhagic polyp. There's also a contact lesion forming on the opposite side where that polyp is hitting over time. Okay, and then sometimes we do see malignancy. So this is an example. We're looking here at this irregular edge. And so when the laryngologist sees something suspicious like this, they will do a biopsy, and he or she will remove as much tissue as possible, maintaining as much of the good tissue as possible to maximize voice. From a neurologic perspective, vocal fold paralysis is a common thing that we see in our practice.
How about if you just
Usually this is happening after some sort of surgery. Happens a lot with thyroid surgery. A lot of times this is temporary if the nerve was just
and then as loud as you can.
pinched
Good
or
breath
stretched or something like that. Very rarely
Good. Low to high.
is the nerve actually severed in the surgery, and in that case it would be more
And
permanent.
high to low.
So in this case you can see that the left vocal fold on the right side is not moving,
Good. Just comfortable.
and instead the opposite cord is doing all of the work.
You
You can see that this left side is bowed, and that happens sometimes if the vocal fold has been paralyzed for a long time, it loses tone. So that's what's happening here. All of this is air that escapes when the person speaks, so they may appear with a very breathy voice like this, and become winded when they're speaking,
and high to low.
have difficulty projecting. Typically when
Good. Just
a
comfortable.
person presents with paralysis, depending on how much closure they get will depend on whether behavioral voice therapy might be appropriate. If in this case that I just showed, they were not getting very good closure, and so there's not a lot that voice therapy could offer in that regard. But if they were paralyzed in a more favorable position, more medially, then it's possible that voice therapy could help them compensate in a more efficient way. In this case, the doctor would probably provide options about doing a temporary injection of some kind of filler to help with the closure pattern. They don't typically like to do anything permanent or long lasting until at least 9 to 12 months after the injury, because oftentimes these things do recover spontaneously. This is another neurologic condition, in this case of vocal tremor. And we're starting back here at the nasopharynx to assess any part of the vocal tract that might have a tremor. So this might be the soft palate, this might be the tongue, the jaw, the head, all of the things that we would be looking out for in addition to the vocal folds themselves.
Hold out an S sound, go and E.
There was a little tremor
Breathe in through your
there
nose.
in the soft palate.
Say E.
And we
Sniff
can
in.
see a tremor here, particularly on this left side.
Good. Sniff and say E like this. E.
They're
Good.
opening and closing
And say
symmetrically.
E. Go
But
high
during
note.
sustained phonation, we see that shakiness.
Good. Just relax. A nice gentle E. High note E. Hold out as long as you can. Nice and strong. E. Can you do?
And so this usually presents mid to late life. It can occur with other types of essential tremor, like hand or limb or neck head tremor. Doesn't have to, it can be an isolated vocal tremor. The medications for tremor are typically not very effective for a vocal tremor, but if the tremor is isolated to the level of the larynx and not just the soft palate or the pharynx, then Botox may provide some benefit to temporarily paralyze the vocal folds. They come back stronger and the tremor is less prevalent. In mild tremor, we can do some behavioral voice therapy to try to shorten the vowel sounds, because the tremor is most prevalent in voiced sounds. And down in the South, where we're used to kind of stretching out all our sounds, but if we make the sounds very short and staccato like this, then the tremor doesn't have as much time to become apparent. This is very cognitively taxing though, so the success rate is pretty limited.
Hold out an S.
And finally, aging voice. we call this presbylarynx. Presbylarynx can happen with any person as they age. We call it presbyphonia when it co-occurs with hoarseness.
Big breath. Can you give me a high pitch? And low pitch.
And so this looked pretty similar to our vocal fold paralysis. Both sides were moving. There is a bit of asymmetry, possibly due to the angle of the scope, but also possibly there just is some asymmetry there. But the vocal fold edges themselves are a little bowed, little thin, loss of muscle and mass over time. And it's creating this spindle shape closure pattern, which means there's lots of air escaping during phonation, which makes them hoarse. In this case, they're getting pretty decent closure, so we might try some voice therapy, but if they feel like they're really struggling still, then an injection would typically be offered. Something more permanent would be like a thyroplasty implant, and that could be done for presbylarynx as well as vocal fold paralysis. So now you've kind of seen under the scope what things look like. Does anybody have any questions so far?
We have a question
Somebody's
in the
asking
chat.
about spastic dysphonia. So spasmodic dysphonia or laryngeal dystonia, they all mean the same thing. It's a neurologic disorder. It's actually one of my areas of expertise. It's a neurologic disorder that causes signals from the brain to make the vocal fold spasm during voicing. It's task specific, so it's not affected. It's when people are whispering or during innate vocal tasks like laughing or crying. But the vocal fold spasms cause voice breaks. They can cause pitch shifts and kind of this creak or aperiodicity to the voice. RFK is somebody who has this disorder. He doesn't get the typical treatment for it, unsurprisingly. But the typical treatment for it is repeated injections of Botox, which are done every 3 to 6 months. So just like for tremor, the vocal folds get very weak for a period of about a week or two. So the voice may get very breathy like this. And then as the vocal fold regains motion, the spasms are reduced for between 3 and 6 months. This is, because it's neurologic, there's not much that can be done from a behavioral standpoint. So currently Botox is sort of the gold standard treatment. Other treatments are being developed, but we have a lack of objective ways to measure this, which is actually where my research focuses. So hopefully the more we figure out how to measure the symptoms, the more we can show effectiveness of different treatment options as they become available. As far as hoarseness, someone's asking hoarseness as a marker of enlarged cardiovascular structures or aortic aneurysm. Certainly if the person has a risk of cardiovascular incidents, definitely the hoarseness can be related to pressure along the recurrent laryngeal nerve or something like that. I wouldn't necessarily jump to that unless, the person is having acute cardiac issues. And then there was actually a study done recently looking at patients with heart failure. They expected the voice to be more hoarse when a person was retaining fluids, but actually the opposite was true. Their voice got a little bit better, and that is because the vocal folds were retaining a little bit of fluid too, which was bulking them up. So they actually sounded better during heart failure than their baseline. Any other questions? All right, so I will end with a few cases then. Okay, so this was my first case back at Emory. This was a 71-year-old woman who was a customer service representative for a credit card company. So she was on the phone all day, every day, dealing with people who were not particularly pleased to be calling in about their credit cards. Her current complaints were a sudden onset of a high-pitched, weak voice that began after an upper respiratory infection. She came to us about 4 weeks after that infection. She reported that her voice occasionally returned to normal for short periods of time, but she could never maintain that normal voice. Past medical history rather, included diabetes, high blood pressure, and hypertension. No surgical history to note. She was a former smoker, smoked a third a pack a day for about 10 years. And so I'm going to play you what her voice sounded like when she came in.
We were away a year ago. The blue spot is on the key again. How hard did it hit him? How hard did he hit him? We eat eggs every Easter. My mom loves making, my mama makes lemon muffins. Peter will keep at the peak.
All right, now can you hold out a nice comfortable ah vowel for me? Good, can you do it lower, like the doctor's voice in your throat? Good. All right. So I would describe her voice as high-pitched, very breathy, and based on that, what do you think you might see given the history of upper respiratory infection 4 weeks ago? Any guesses? My guess was going to be a vocal fold paralysis. Sometimes we'll see that after an upper respiratory infection. So this is what we saw. And I'm sorry, there's no sound for this video and the video is not great, but what we do see is that her muscles are compensating. The vocal fold edges themselves, although they're difficult to see because of all of the muscle tension, are actually quite normal. So there's a lot of anterior, posterior, and lateral compression there. False folds are almost completely covering the vocal folds. So we call this muscle tension dysphonia. And so the primary treatment for muscle tension dysphonia is voice therapy. So she began voice therapy with me.
We were away a year ago.
And she had 5 sessions of voice therapy. During the evaluation, I showed her how to get more efficient voicing with the use of what we call semi-occluded vocal tract tasks. Basically what this does is we occlude the vocal tract, so somewhere in the nose or mouth, which sends pressure back towards the vocal folds that allows them to vibrate with the least amount of effort or collision force as possible. And it's sort of just a way of recalibrating the system, getting the muscles to get out of the way so that they can feel more vibration up in what I call the mask. So the oral cavities, the nasal cavities, that's what gives us our nice resonant sound. So this kind of acts like a megaphone so that we're not having to do work muscularly at the level of the throat, but the vocal folds are vibrating at the level of throat and the sound's bouncing around in the nasal and oral cavities. So humming is an example of a semi-occluded vocal tract task. So just a gentle or if they can get their air and their voice coordinated with something like that. Straw phonation is another option. We literally have them blow bubbles into a cup, which seems very silly, but they do it with voice. The cup, the water adds a little bit of resistance, and the water also allows a visual feedback about how much air they're using. Some people really are holding back their air, and so if they're not letting their air go, then you won't see bubbles in the water, and so that can be really effective for people who have gotten into this maladaptive pattern. So she was able to do that and was able to maintain a somewhat normal voice after doing those exercises. So we had her start out doing those, 3 to 5 times throughout the day, just for a couple of minutes. And then we got her in for therapy. So the first full therapy session, we carried this over to conversation. There is a specific therapy called conversation training therapy, which was actually developed by one of our speech pathologists here, Amanda Gillespie. It uses clear, crisp speech, which I'll also show you an example of in just a few minutes. We also worked on resonant voice, and then we had her practice do negative practice. So once she got a better voice out, then occasionally I would say, okay, now I want you to, on purpose, make your high-pitched, strained voice. And so she would go back to this high pitch, and then I would say, okay, now I want you to fix it. And she was able to do that. And the more she was able to go back and forth between the two voices, the more in control she felt over her voice. She was continuing to struggle with her job because she was literally on the phone all day long. Her company was not very flexible with her for accommodations. So she struggled a lot with fatigue at the end of the day, or her voice would give out at the end of the day. But gradually over time, after about 5 sessions, she reported that she was 85 to 90% better. She was able to get back to full-time work. She was still fatigued at the end of the day, but she wasn't losing her voice anymore. And she felt like she had all the tools that she needed to continue working on her voice on her own. We asked her to come in for a post-therapy visit to just take a look at things and get some post-therapy measures. So she came in about 6 weeks after our last session, and this is what she sounded like.
We were away a year ago. The blue spot is on the key again. How hard did he hit him? We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
Nice. And can you give me a nice, clear vowel? And just hold it out on one single pitch. Good. And so much improved compared to how she started.
We were away a year ago. The blue spot is on the key.
So her real voice was much lower. There was a little bit of graveliness there, but nothing that bothered her, and certainly was a more functional voice than what she came in with.
We were.
All right, case number 2. This was a 65-year-old man who presented with hoarseness. He had had several months of hoarseness and described his voice as rough. He reported that he occasionally cheers for the Steelers and possibly was yelling at a game. He does not use tobacco. He drinks 1 to 2 cups of coffee per day, but no other social factors that are relevant. And this is what he sounded like.
The rainbow is the division of the white light into many beautiful colors. These make the shape of a long, round arch with its path high above and its 2 ends apparently beyond the horizon.
And this is his exam. So he actually looks worse than he sounds. But we see a hemorrhagic, broad-based polyp on the left vocal fold, which is on the right side of the screen. There's some yellow in the cord indicating that some of it is healing, but there likely was a hemorrhage throughout. And this probably was due to yelling. Typically these things happen pretty quickly.
Can you match my pitch?
But because it's more on the surface, it's not impacting vibration as much.
And now really high pitch.
And of course, as he raises his pitch, he gets a little bit breathy. But given that his voice is low pitched, he's pretty much able to do all the things that he wants to do. So he, again, sounded better than he looked. So I believe that he just did voice therapy. He did not opt to have surgery because he didn't have any major demands and felt like, you know, he sounded pretty good at baseline. So he wanted to give therapy a shot. And so likely the speech pathologist worked on reducing collision force, probably doing similar things with the semi-occluded tasks, conversation training, and then probably teaching him to project his voice in a healthier way without as much collision. So this is what he looked like after therapy. We can still see some blood in the cords that appears to be resolving. But he's getting better closure, and the polyp itself is gone. Any questions so far? All right, and then the last case that I have is a 70-year-old woman, gradual onset of raspiness over time. She describes her voice as gravelly. She was diagnosed with presbyphonia and vocal fold atrophy with compensatory muscle tension dysphonia. I don't have a strobe for her, but as the primary reason for dysphonia was the muscle tension compensating for a little bit of vocal fold atrophy, she was treated with voice therapy. And so I mentioned conversation training therapy, which was pioneered by Amanda Gillespie, who's a speech pathologist on our team. And this therapy focuses on training target voice therapy goals in spontaneous, patient-driven conversational speech, because people are not going to go around blowing bubbles in real life or doing lip trills or things like that. So we are transferring good vocal behaviors into real conversation in the first session, which increases buy-in and improve it. It basically makes them better faster. And so this is after a few sessions of voice therapy.
Give me an example of the voice that bothers you. You were saying you're driving to Florida.
Yeah, this is the voice that bothers me, but it comes natural.
Yeah, and it feels how?
It feels gravelly. There's nothing smooth about it, and it's not bothersome to me because it comes naturally.
Yeah.
But I know it's bothersome to other people.
Yeah, so you've gotten used to it.
I'm very used to it.
And if you switch to the other voice, the crisp, clear speech,
Yes.
where you kind of spit out the consonants, how does that sound?
That one makes me talk slower because I have to think a little bit right now. But it's very smooth, very easy when I talk, but not as easy as if I let it go right back.
Right. So when you say easy, do you mean the effort in thinking about it, or the effort in making it like a physical effort or a mental effort?
When I talk like this, I can actually feel it not smooth.
Yeah.
It's very, very bumpy.
Yeah.
But when I throw it forward, there's a smoothness to it. There's not that bumpiness.
Yeah. Yeah. But you have to think more about.
I have to think.
Yeah.
And that's making me talk a little slower because I do need to think.
Yeah, and it's
new.
new.
If I don't think, it's going to go right back
Right,
there.
right. Because it's a new thing. You've only been doing it for a few minutes. So if we were to label these two voices, what would you call them? Something that will make it relevant to you, that you'll remember the next time.
The one that's this and not smooth, I would call it pebbles.
Oh, I love it. Pebbles, perfect. Yeah. And how about the other one?
This one would be more like silky.
Yeah. Okay.
So we have them label their voices, and then we have them practice flipping back between the two voices so that they have control over that. So hopefully that gives you a little taste of what we do in voice therapy. I always describe voice therapy as kind of like physical therapy for the voice. That seems to be a concept people are easily grasp onto. And again, we usually start the same day that they're seen in the clinic, which helps again with buy-in, because people are like, voice therapy, what is that? I don't think that's going to help. But if they can see differences that same day, then that typically is helpful for them to buy in and make changes. Any questions about that? And so to end, I thought we could take a look at people who've been in the media to give you more examples of voice disorders. So you may remember Dr. Fauci had a vocal cord polyp. Sorry about this.
When I first came to Southeast, the first building was under construction, but the church met in the basement of a house. And
let's try this one. This is RFK.
Looking for a reputable contractor for your next home improvement project?
Someone just asked how quickly our patients typically get scheduled. It depends. I think usually it's 1 to 2 months. However, some people are getting lucky by scheduling through the through MyChart app, and then they can see what appointments are available, and so then they can get in a little sooner. I will say if you have somebody that needs to be seen more urgently, send a message to any of our providers through MyChart, or rather through Epic, and we're always happy to try to get them in sooner. There's also a trend in some circles where people intentionally sound breathy. Is there any long-term harm associated with that? Do you mean stylistically, or stylistically? Probably not. Breathy voice is typically associated with less vocal fold contact, so theoretically they're not at risk for phonotrauma. However, if they're doing that with muscle tension to hold the vocal folds apart to get that breathiness, then they could be affecting their vocal efficiency, which could cause problems over time muscularly, but they're not physically at risk of phonotrauma, if that makes sense. For non-Epic community practices, I would say call the Voice Center phone number, which will take you to the call center. They can put in a message to our nurse and try to get the patient seen sooner.
everybody
Dixon
knew
Painting, in business since 2003.
that it was about to.
Anyway, I'll let you look them up. Dr. Fauci had a vocal fold polyp. RFK has laryngeal dystonia or spasmodic dysphonia. I mentioned he doesn't do the typical Botox injections. He actually went to Japan and got kind of I think it's a barbaric surgery. to bring the vocal folds together. I don't think he sounds very good, but some people really have a problem with the up and down of their voice, so he probably felt like the surgery was at least going to make him more consistent, even if he doesn't sound very good. Bon Jovi actually had vocal fold atrophy, and he's had a vocal fold implant, actually. And then Miley Cyrus had Ranke's edema. If you look up videos of her young and then her current, her voice has dropped in pitch drastically. She sounds like a smoker. Ranke's edema is also known as smoker's polyps. I'm not saying she smokes, she might, I'm not sure, but she is a very, very heavy voice user, talked about drinking that she was doing. And so all of those things can contribute to that Ranke's space, which is the middle layer of the vocal folds getting inflamed, and this Ranke's edema causes what we hear as a smoker's voice. And this was treated surgically with a laser to shrink down some of that edema.
Our family-owned company.
So again, sorry my videos didn't
I chose
work here.
Wix
If
for
you're a
my videos
professional
because
woman-
it's massive.
Sorry about that. All right, so in summary, hoarseness lasting 2 weeks or longer is never normal. Imaging is needed. Please refer for video stroboscopy. So the stroboscopy part is the important part, and it's typically not available in general ENT practices. And you also want to know the red flags that make you suspicious of cancer. Contact the physician that you're going to refer to in order to expedite that evaluation. So thinking about pain, weight loss, fever, fatigue, that sort of thing. Thank you so much for having me talk today. This is the Emory Voice Center website. And if you have any questions or concerns, feel free to email me.
Thank you, Dr. Marks, for that really excellent talk. I appreciate both the differential you gave us as we think about these patients, as well as the videos. I'm always impressed when someone can get the audio to work on a Zoom, which is tricky at best for many of us, myself included. Any questions from our audience? All right. Well, with that, we'll end our recording. Thank you again, Dr. Marks, and thanks everyone for being here. Have a great rest.